Welcome back to Discussions with Dr. G. Today's discussion is going to be on growth factors. I'm your sarcastic professor, and let's be honest, a nurse who's seen more blood cell counts than I care to admit. Today we're talking about managing blood cell growth. And no, I'm not talking about that time your toddler's knees look like a connect the dots puzzle. We're diving into hematopoietic growth factors, the stuff that tells your bone marrow to get off the couch and make some cells. So what are these growth factors and why do we need different ones? Well, think of your bone marrow as a factory, but it's got different assembly lines. Erythropoietic agents like epoetin alpha and darbepoetin alpha are basically the managers yelling, "Hey, make more red blood cells." That's your oxygen delivery team, right? Then you've got leukopoietic agents, filgrastim and pegfilgrastim, who are all about neutrophils, the infection-fighting crew. And if you really want to get fancy, there's GM-CSF, like sargramostim, which is like a drill sergeant for multiple cell types, neutrophils, monocytes, macrophages, diversity hiring at its finest. So why do we need different factors? Well, each blood cell type has its own job, and you don't want your red cells moonlighting as infection fighters. That'd be a disaster. So we use specific agents to target the right cell line. Epoetin for red cells, filgrastim for neutrophils, and sargramostim for a little bit of everything. It's like picking the right tool for the job. Don't use a crochet hook to paint your living room, right? All right. Now let's talk about how we actually use these cells in real life. Epoetin alpha and darbepoetin alpha are the go-tos for anemia, especially in chronic kidney disease, chemo-induced anemia, or even HIV patients that are on zidovudine. Basically, if your patient's looking a little too pale, these are your friends. But, and this is a big but, you gotta watch out for hypertension and keep that hemoglobin under 11. This isn't a contest to see who can get the highest number, all right? Then there's filgrastim and pegfilgrastim. These are lifesavers for patients going through chemo who end up neutropenic, meaning their infection-fighting cells are wiped out. Let's say you have a patient who's getting hammered by chemo. Her neutrophil count tanks, and you get an order to start her on filgrastim. Within days, her counts bounce back and she avoids a nasty infection. But she may complain her bones feel like they've been running a marathon. Okay, that's normal. Bone pain is a classic side effect. It's not fun, but it is better than sepsis. And then there's sargramostim, which is a kind of an overachiever. We use it after bone marrow transplants or if the transplant flops. It helps recover not just neutrophils, but also monocytes and macrophages. Heads up, first dose can make patients feel like they've just run a marathon. Tachycardia, fever, chills, the whole 9 yards. All right, let's get real about risks and side effects because nothing in medicine is ever just sunshine and rainbows. With erythropoietic agents, hypertension is super common. And if you let that hemoglobin climb too high, you're asking for a thrombotic event. Think stroke or clot. Not exactly the outcome we're aiming for. Headaches and body aches are pretty standard too. For filgrastim and pegfilgrastim, bone pain is almost a given. But the rare stuff, splenic rupture, yeah, your spleen can actually burst. If a patient calls in with left upper quadrant pain or weird shoulder pain, don't tell them to just walk it off. That's a 911 moment. And with sargramostim, you've got to watch out for that first dose reaction of tachycardia, hypotension, fever, chills. It's like your body's throwing a fit because it wasn't warned that you were going to go and hire all of these extra leukocytes, monocytes, and macrophages. All right? Okay. Monitoring is everything. Blood pressure, CBCs, watching for signs of adverse effects. If you skip the monitoring, you're basically flying blind. I mean, you would drive a car with no dashboard? No, I didn't think so. If you miss a spike in blood pressure or a drop in platelets, things can go south fast. That's why we check labs, teach patients what to look for, and keep a close eye on everything. It's really not about being paranoid, guys. It's about keeping people safe. So let's wrap this up, shall we? Managing blood cell growth with these agents is a balancing act. The benefits are huge, but you've got to respect the risks and monitor like your patient's life depends on it. Because really, it kind of does. Thanks for hanging out with me today. Next time we'll dig into more medication classes, so don't miss out. Go check your blood pressure. I'll see you soon.